Allergic reactions. Allergic reactions are very common. Many people have allergies, whether they be seasonal allergies, whether they be allergies to cat dander or dog dander, or allergies to food. Some allergic reactions can be severe enough to cause shock and death, and we call those anaphylactic reactions. So an allergic reaction is when the immune system naturally responds to a foreign substance in the body, usually a protein. During an allergic reaction, there's an exaggerated response to this foreign substance. Again, it's usually a protein. The allergen is what we call the substance that causes the exaggerated effect. So people who are allergic to peanuts, the allergen is the peanut. Now, inside of an allergic reaction, when you are first exposed to a foreign substance, your immune system develops antibodies. And antibodies are designed to identify and attack a particular foreign substance. So we have many antibodies in our system, so that when exposed to a harmful substance like a foreign protein, our antibodies will identify and attempt to attack that foreign substance and render it harmless. So antibodies combine only with the allergen they were formed in response to. So that's why we have so many different antibodies. We have an antibody for each allergen we've been exposed to. Now, when you're exposed to that a second time, the antibodies are already there. The antibody combines with the allergen, and it leads to the release of histamine, bradykinin, and about 6 other inflammatory mediators that go into your bloodstream. These chemicals cause harmful effects in too large amounts. So under normal circumstances, when you're exposed to this allergen that you developed an antibody to, the antibody identifies and attacks that allergen, rendering it harmless. And in most situations, there's little or any evidence of this occurring. But when the amount of histamine, bradykinin, and other inflammatory mediators increases, we start to see symptoms, initially as an allergic reaction, and if the antibody-antigen reaction is severe, then we see anaphylactic shock. So outside, the effects of the histamine and other chemicals will cause swelling, will cause bronchoconstriction, and will cause vasodilation. The swelling we see as evidence in the face, the tongue, around the eyes, hives or urticaria. The bronchoconstriction we see with wheezing, hard to breathe, and the vasodilation is where we get the shock. If the vessels dilate large enough, the container is twice as big, so it's half as full, and it makes it very difficult to maintain pressure in the system. So anaphylaxis is a severe life-threatening allergic reaction. Because of this over-exaggerated release of histamine and other chemicals, it'll cause a rapid dilation of the blood vessels, which lead to the hypotension, the airway swelling, which leads to airway obstruction, and the bronchoconstriction, which constricts the bronchioles down so you can't get air into your lungs, which leads to respiratory failure. So the hypotension, the airway obstruction, and the respiratory failure is what leads to death and anaphylaxis. And this can occur quickly, within minutes of exposure to an allergen. Some common allergens include insects, particularly Hymenopteras or bees, foods, plants, medications, and then things like dust, makeup, soap, colognes, perfumes, those sort of things. And here are just an example of common allergens. Now, latex allergy is something that we saw with the advent of the requirement that all healthcare providers had to wear gloves. Initially, the gloves that were being produced were latex. And because all healthcare providers had to wear them, there weren't enough latex gloves being made to supply everybody that had to wear them. So companies cropped up all over the place. Production was least expensive to get it done, to mass produce these gloves quickly. And as a result, the latex gloves weren't washed properly, and large protein molecules were left in the gloves, on the gloves, to be absorbed through the skin when the wearer put them on. Now, it isn't the powder that came on or in the glove. It's the large proteins from not washing the latex, the rubber latex, properly. And so many patients, particularly women, because there are more women in healthcare than men, develop these latex sensitivities. So exposure of these inexpensive latex gloves led to this development of this latex allergy. We've always known that latex allergy can occur in patients that have a history of other allergies. Latex allergies can occur in chronic exposure to latex in spina bifida patients who are constantly being exposed to sterile latex gloves during surgeries. They're often given a balloon to blow to help them with bowel control. And so they're constantly being exposed to latex, and they too develop latex allergies. They can be so severe that even eating lettuce by latex gloves, where a worker has torn the lettuce while wearing latex gloves, and a person has a latex allergy and they eat that lettuce, they can have a full-blown anaphylactic shock. That's why things like latex balloons have been banned in hospitals. Latex gloves essentially have been banned in hospitals. They've been replaced with nitrile and vinyl gloves rather than latex. There's no way to predict the exact course of an allergic reaction, whether it's going to be mild or whether it's going to be severe or whether it's going to be anaphylactic. But severe reaction often takes place immediately, but it can be delayed 30 minutes or more. That's why if you receive an injection or a shot or an immunization, they like you to stay around for about 15 or 20 minutes, because you may not have a reaction immediately to your injection, but 15 minutes, 20 minutes later you may. Even a mild allergic reaction can rapidly progress to anaphylaxis, so there's just no way to predict that. Signs and symptoms of an allergic reaction include itching, hives, or what we call urticaria. It's a red raised rash on the body that if you push on it, it blanches white and then fills back in with red. The rest of their skin may be flushed. They may have swelling of the face, may have warm, tingly feelings in the face, the mouth, the chest, the feet, or the hands. They may complain of some chest tightness. Now here's a person having an allergic reaction with some facial swelling. So we can see the swelling around that right eye. Here are hives, probably in that same individual. You can see the raised red rash. Again, when you push on that, it turns white and it fills right back in with red. In addition to what we've talked about, they can have respiratory signs and symptoms, a tightness in their throat or chest as the swelling continues. They may develop a cough. Their breathing may be labored or noisy. You may hear a stridor from upper airway obstruction or wheezing from bronchoconstriction. Their voice may be muffled or hoarse, or they may lose their voice, or have what is referred to as a hot potato voice, when you have hot potatoes in your mouth, how you might sound. The cardiac signs and symptoms, because of the shock, you're going to see an increase in heart rate and a decrease in blood pressure. Eyes can be itchy and watery. They can have a headache, a runny nose, and certainly a sense of impending doom if they're becoming hypoxic from the upper airway swelling and the bronchoconstriction. As the allergic reaction continues into anaphylaxis, they can have altered mental status. Their skin can be flushed. When they go into shock, can be pale, cool, and clammy. In addition to everything that we're seeing, gut motility increases. So during an anaphylactic reaction, they get a lot of GI upset, a lot of gastrointestinal upset. They feel sick to their stomach. They may vomit. They may have diarrhea. And then you see, again, the signs of shock: an increased pulse, an increased breathing, and eventually a drop in blood pressure. Now, distinguishing anaphylaxis from an allergic reaction is important because anaphylaxis, we're going to administer an epinephrine pen. With a mild allergic reaction, we're not going to do anything other than encourage them to take some Benadryl or see their doctor. Now, if a person has had any of the previous signs and symptoms that we talked about, that can be an allergic reaction. But when a person develops anaphylaxis, that's where we see the systemic involvement. Not only do they have the watery, itchy eyes, runny nose, the hives, chest tightness, that sort of stuff, but now we start to see the signs and symptoms of shock. That's when we have anaphylaxis. They're complaining of a hard time breathing. Their skin is pale, cool, and clammy. Their heart rate is up. Their respiratory rate is up, and their blood pressure may be dropping. Anaphylaxis is a life threat, and the life threat comes from airway obstruction as well as bronchoconstriction and shock. So assessing the airway to make sure that it's open if there are heavy secretions and the patient is not responsive, you may have to suction those out. If their breathing is not adequate, you may have to assist their breathing with a bag mask and 100% oxygen, and it certainly would be appropriate to give them oxygen by mask if they're having an allergic reaction or anaphylaxis. Support their circulation by if they go into cardiac arrest from their anaphylaxis, doing CPR. You want to note whether or not they have a history of allergies. Are they allergic to bees? And if so, were they just stung by a bee? You want to know if they, what had they been exposed to? How did the exposure occurred? How did it get into the body? Was it a bee sting? Was it absorbed through the skin? Was it inhaled into the lungs? Was it ingested? What other signs and symptoms are you seeing that might indicate allergic reaction or anaphylaxis? And is it getting worse? And then what have they done prior to your arrival? Excuse me. Patients with anaphylaxis or who know they have severe allergies to bees or those sort of things may carry their own epinephrine pen, and they may administer their own epinephrine pen before you arrive. You want to assess their baseline vitals to see whether or not there's any signs or symptoms of shock, and try to get the remainder of their past medical history related to allergies. Patient care would include, managing the ABCs, high concentration of oxygen. Mild allergic reactions don't need oxygen, but certainly anaphylaxis does. And again, as I mentioned, if the patient isn't breathing adequately, then you need to provide artificial ventilations. If the patient has their own auto-injector epinephrine pen and hasn't used it, as an EMT, you certainly can administer that epinephrine auto-injector. In Iowa, your service can carry an epinephrine auto-injector if your medical director allows, and you could administer the epinephrine auto-injector if the patient you're caring for was having an anaphylactic reaction. If the patient is not wheezing or showing signs of respiratory distress or shock, then you just want to continue with your assessment and consult your medical director about whether you should use an auto-injector or not. Now, the absence of wheezing, the presence of wheezing indicates bronchoconstriction or bronchospasm. The absence of wheezing doesn't mean that that's occurring. For a patient to wheeze or whistle, they got to move enough air. If their bronchioles constrict really tight, they're not going to move enough air to wheeze. So the absence of wheezing could be a good thing if their pulse oximetry is normal and they're not complaining of shortness of breath and don't have any signs of shock. But if the wheezing is absent and they have serious signs and symptoms, then their bronchioles are so tight that they can't move enough air to wheeze, and they are likely going to go into respiratory arrest. When use of an auto-injector may be appropriate is when the patient has come in contact with a substance that they know causes anaphylaxis. If they're severely allergic to bees and they tell you they've been stung by a bee, an epinephrine auto-injector would be appropriate. If the patient exhibits signs and symptoms of anaphylaxis, respiratory distress, or signs and symptoms of shock, an auto-injector would be appropriate. After using the auto-injector, record the administration and then transport the patient. You want to reassess the patient after 2 minutes. It's going to take time depending on the degree of shock with an auto-injector. When you use an auto-injector, you're automatically injecting epinephrine into the muscle. And that's going to take maybe up to 10 or 15 minutes to work, depending on the blood flow through that muscle. So you want to reassess your patient frequently to see if they're getting better or worse. But understand, an epi-auto-injector is not like giving a medication IV where we see the results immediately. Make sure that you reassess after giving the auto-injector while taking the patient to the hospital. Self-administered auto-injector epinephrine pens are commonly prescribed to patients who have a history of allergies. Many patients will carry them. They even have nice little designer carrying cases that a child or somebody conscious of style could wear it under their clothing or around their ankle or something like that, so it would go unnoticed around other children. Schools have epinephrine auto-injectors in the nursing office because of all the peanut allergies. So auto-injectors are common. Epinephrine is a hormone that's produced by the body. Epinephrine, epi means above, nephr refers to the kidneys, and epinephrine is the same substance that the kidneys release from the adrenal glands. The adrenal glands sit on top of the kidneys, and they release adrenaline. Now, epinephrine constricts blood vessels and it dilates bronchioles. So giving a person having an anaphylactic reaction an epinephrine auto-injector constricts their blood vessels that are fully dilated and helps maintain pressure in the system, but also dilates their bronchioles so they can breathe easier. In Iowa, you certainly can be authorized by your medical director to administer an epinephrine pen in a patient who carries their own, but also in Iowa, as a service, your service is allowed to carry an epinephrine auto-injector that you could administer to a patient who's having anaphylaxis but doesn't have an EpiPen. Side effects of epinephrine, it's adrenaline. It's going to make your heart beat faster. So patients may get a little jittery, their heart rate may be, in the 120s, 130s, and that's also going to put an increased cardiac workload on the heart. And, it's a consequence. It certainly is something that's going to happen, and you have to weigh the risk-benefit. The benefit of increasing the workload of the heart, the risk of increasing the workload on the heart isn't as important as the benefit of maintaining blood pressure and allowing the patient to breathe easier. Patients with sick hearts, giving them epinephrine could be problematic. So if you have an older patient who has cardiac disease or coronary artery disease, and you have to give them epinephrine, and their heart has to work a lot faster and stronger, they may actually develop chest pain, heart-related chest pain. The auto-injector is a spring-loaded needle and syringe that has a single dose of epinephrine. There is an adult dose, which is 0.5 milligrams, and there is a pediatric dose, there's an adult dose with 0.3 milligrams of adrenaline to be given IM, and there's a pediatric dose of 0.15 milligrams that would be given IM. Upon pressing the device against the thigh, the mid-thigh, the medication is automatically released and injects into the muscle where it goes to work in about 5 minutes or so. Here's an example of an older epinephrine pen. This is a first-generation epinephrine pen. There aren't many of these available. And the concern with these, they worked great, but when you pulled this out of the patient's, away from the patient's thigh, there was about an inch-long needle sticking out of the end of there. And if you poke yourself with it, now you've got a significant exposure because you've poked yourself with a needle that's been in somebody's body. The newer generation EpiPens have a self-sheathing cap that slides over the needle when you pull it away from the thigh, protecting you from getting stuck. To administer an auto-injector, you have to obtain the patient's prescription auto-injector and ensure that this EpiPen is for this patient. There is a window in the EpiPen where you can look at the medication. The medication should be clear. If the medication is cloudy, if the medication is yellow, if there are floaties in it, obviously the medication is no good. You want to look to see the expiration date, but epinephrine pens can be used well beyond their expiration date as long as the medication window, that liquid, is clear. You can just follow a protocol here in Iowa. Other states, you may have to call medical direction prior to administering an EpiPen. You want to remove the safety cap and press the tip of the auto-injector firmly against the thigh between the knee and the waist, so halfway between the thigh. Hold it in place a full 10 seconds, allowing all the medication to be injected. Record and administer the time that it was injected, and then carefully dispose of the injector in a biohazard container. It is safe. Save it if it's a 2-dose injector. If it's one of those that you could give a second dose from. They do exist, but most people have just single auto-injectors and may carry 2 EpiPens. Reassessment should show that the patient is getting better, but if your reassessment shows that the patient is getting worse, they're going to need additional doses of epinephrine. And if you don't have that, you may have to make certain that you have ALS on their way so that you can tear up with them because they have the epinephrine not only in, they may have it in an auto-injector, but they also have it in an ampule or a vial. So if no auto-injector is available, or you need a second auto-injector, or you need more epinephrine or additional doses of epinephrine, request an ALS intercept and begin treating for shock. Again, there are 2 sizes of auto-injectors. The adult is 0.3 milligrams. The child is 0.15 milligrams. But the reality is the epinephrine dose in children, you can go anywhere from 0.1 to 0.5 milligrams of epinephrine in a child. So even if all you had was an adult EpiPen and you had a child in anaphylaxis, giving that 0.3 milligrams would not be harmful. All right, so that covers our discussions on allergic reactions. If you have any questions, you know how to get a hold of me.